Good morning, everyone. Good morning. Good morning. So yes, I'm Brianna Smith. You guys probably remember me from Wednesday. If not, I do community engaged sickle cell research at UCLA, and I'm just really happy to be here. Really happy to be here. So Dr. Rowley asked me to do just a little summary and get you guys ready for the last day of our summit. Also, just a little plug, if you want to sign up for the pain management focus group and you haven't yet, please come see me. We really want your opinions and we want your participation. So, have you all been enjoying the summit so far? Let's hear it, let's hear it. Okay. I know I've really been enjoying it. This is my second year attending this summit, and I've learned so much, not only from the professional talks that we've heard, but also from the stories of the warriors, the caregivers, and families. It's been very impactful. And it just makes me really excited to continue doing this research that I do. So does anyone have any highlights from the week? Any sessions you really liked? Anything you enjoyed? Let's shout it out. Let's hear it. Jay Snow, yes. I really loved that documentary. Did anyone else? Yes. Let's clap it up for that. Yeah, if you missed that documentary on Wednesday night, you missed out because it was truly amazing, truly amazing. Like some of my friends asked what kind of research I do and what sickle cell disease is. I want to show them that movie so they can know what it is. Doctor to Doctor was also, if anyone doesn't know, Thursday night, the doctors were able to have a dinner, and we also had a panel from doctors that have sickle cell disease themselves, which was truly inspiring. I honestly was just really shocked by some of the things that I heard and how that medical side for them can also sometimes get them better care and how they wrestle with that. It was just really interesting to hear that perspective because we don't really hear that a lot. Anything else? The men's group. They had a good time. You were in there, it was good? Okay, yes. It's so amazing that we get to do that too. Awesome. Anyone else want to shout? Yes, Dr. Vista sharing the history with the Black Panthers and everything like that. Just so important. Great history. Yes, amazing. Yes, okay, the pain management session. Yup, absolutely. I enjoyed that too. Yup, the drummers, yup.
Walking around talking to people.
Yes. No, this is a great place just to get to know people, get to know their stories, make relationships. Like, I love this summit. Like I said, this is my second year coming, and I always leave just feeling better than I came. So I'm really...
Scar stories.
Yes, the scar stories, yes. If you haven't had a chance to go in there and see those photographs, they are truly beautiful, very powerful. So what room is it in? Salon 2. So if you hadn't had a chance to see the Scar Stories project yet, please go to Salon 2 and see that. Yes, we were dancing, we were eating, we had a good time, yes. Yes, I love to see those doctors on the dance floor too, yeah. Yes, Dr. Lynn, yes, talking from the nursing perspective, absolutely. And just the story that she shared was very powerful, absolutely. Yeah, thank you guys for sharing that. Like, you guys honestly said everything that I was gonna say in terms of my favorite. Another, just to highlight, I really love the warrior panel yesterday, talking about pain management and just what gets them through the pain. And that was really inspiring for me to hear. It's just so amazing, so fulfilling, I love it. So on this last day of the summit, we're going to hear from many different speakers about topics related to pain management, alternative and complementary therapies, and also the duality of pain. We'll also hear some success stories, spoken word, and we'll finish it out with a skit in our down-home fireside chat. I hope you all really learn a lot today and enjoy yourselves on this last day. Thank you all for attending, and a special thank you to Dr. Rowley and Nurse Pat for allowing me. Yeah, let's give it up. Yes. Yeah. Thank you. Yes, love you too. Thank you guys just for allowing me to be part of the planning committee again and just being able to see the hard work that goes into putting on a summit like this. It starts basically a year out. So just so y'all know, those planning meetings, all those logistics, everything, this is being planned very far in advance just to make sure that everything runs smoothly. So just amazing to see that. Just the whole Cayenne team, you guys really work so hard and they really care about this community and they do this amazing event every year. Just glad to be a part of it. So I've learned so much and I really hope to continue to be a part of this community as I do this work. Thank you all and let's have an amazing final day.
Good morning, everyone. How are you doing? So, I am so delighted to be here, and thank you for inviting me to be a part of this amazingly warm group is my good fortune. And I am really bringing a message of strength, hope, and being together. So the idea is not just science, but it's all of us together, the community. And the community means everyone, the people around us, the people we interact with, and these are the warriors who come first. Second, the teams that take care of them. And more than that, sometimes we forget. I still don't see my slides here. Not the caregivers who are hospital-based or advocates, but the people like mothers, children, sisters, friends. They suffer along with the suffering of each of us whenever we suffer. So I still don't see the slides. So I want us to go home happy. And so I would call this a happy hour. Why shouldn't we have a happy hour when we do anything? We should rejoice our getting together, learning from each other, and creating more hope, and see how much we have accomplished and how we care for each other. And this is what Dr. Rowley has done, brought us all together. And I must say congratulations to her for this successful gathering, and also her efforts we all have to recognize. Is it going to show there? You're working on it? Okay. Well, I hope my slides will show up, and I can show you how what I am saying is actually true, how all of us are together in this, and how our environment and everyone affects us in everyday life to make us happy, keep our peace. Like today, we had such an amazing start with a prayer, and then with the movement. Did you give us your slides? Yeah, I did. Yesterday. He has them. He saw them. They were there. I have my computer if you want it. It's on this. Okay. Excuse me, please. Yeah. Yeah, no, I'm just bringing it to the first slide. They claim they may have found it. Boom. Oh, okay. Yes. Now, can I? No, you got.
Oh, we got slides. We love the slides. Give a round of applause for the slides. Dr. Cooper, we're going to give you some time back. Here we go.
There we go. So this is great. This is a big success story. See the magic of science. We got the slides back. So that's why I named my topic today, Working Towards the Challenge. It's a challenge, and I will show you why it is a challenge and unique, and together we stand, all of us. These are my disclosures, not much. Now we have known, as we learned from the history and several...
Hold it up to your mouth.
Okay, and too many instructions for me, right? Not used to them. My husband says I can't take instruction very well, so I'm sure it's common all along. So And we are experts on sickle cell from many angles by now. But my biggest question that haunts me day and night is, why is there pain if there is sickle cell disease? And we don't know the answer. We are still trying to find out. We have sent the man on moon in the last 3/4 of a century since we learned that it is a molecular disease. Why is it that we don't understand it fully and we can't resolve it? What is the challenge? The challenge is here. On the left-hand side, you see the sickle cell pathobiology. It's not just that one amino acid. That one amino acid really shakes the world inside the person. Everything goes wrong. But it is not just the red blood cells, not just the blood, not just the nitric oxide. Look at the top picture with those multiple miles-long nerve fibers, which are responsible for communicating pain. And then just a little section of the brain that you see here is one of the most complicated entities in the body. How are they interacting and influencing with each other? And when there is pain generated by these processes, and it causes organ damage, cognitive impairment, they're all together. They are not isolated. And that is why it's not just all of us together, but all of these entities together are causing a mayhem. And then there is the social fabric, which includes sleep. And we heard about all these climate, nutrition. Very little emphasis is paid to nutrition, and it is very important. Because in sickle cell disease, the metabolic requirement or the requirement to make the energy currency called ATP is very high because of ongoing hemolysis, making more red cells, coping with organ damage. And then there is isolation, fear, trauma, anxiety, and pain. They all feed into each other. And we have to understand all of it. And that is why the theme is all of it together. How do we plan to navigate this challenge? It's much more complicated than we think of. Number one, we already know that pain in sickle cell disease is very unique. It may span the entire lifespan of a person, unlike many other conditions. There is isolation at multiple levels, and togetherness is strength. We are not alone. Let's say this, we are not alone. And isolation at multiple levels does not mean that the warriors are only isolated. We, the team of scientists, are also isolated, working in our own silos, shaking our own tubes, and be happy. That should not be the model. The caregivers, only the physician is not the one who is treating, but the whole team who have to understand the person as well as the disease. And there is scientific evidence that companionship and nutrition improve analgesia. And I will show you a very small part of the evidence. And as I showed earlier, pain is multimodal, involving the whole person. So we have to come up with whole person approaches. And then we have to understand interoception. How many of you have heard the word interoception before? None of the hands went up. So let's practice, say, oh, there is one person in the back from our IT team. Big hand to you. Okay, so say interoception. Say it again. Wow, say it again. There we go. So what is it? Interoception. I'll start explaining it by the work of our own Hertz-Nazer, who expressed pain in the best way. It cannot be defined by a number. And that's what interoception will tell us, as I will explain it to you. And this painting is not a work of art, it's a work of feelings. It's conveying interoception to you. And he writes, what the pain of sickle cell disease feels like for me. I wish to inspire empathy and compassion in others so that we may someday end the suffering of the sickle cell community worldwide. And I tell you, it's very inspiring. Every time I look at it, I say, we got to work harder. So what is interoception? It's not new. Maybe in 1950s, a priest who was also considered a philosopher, mathematician, and scientist said that there is communication between the environment, mind, and body. And humans are a union of mind and body. And what we do when we study pain, we separate them. We say it's the mind, it's the nervous system, but that's not true. And he said that psychosomatic processes, which means whatever emerges from the body and reactions in man, with an emphasis on emotions and passions. And he said that the spirit flows through the body. The spirit does flow through the body in philosophical terms, but what we see spirit is blood. We know blood. That time they didn't know that there is blood. Blood flows through the body. And what happens to the blood in sickle cell disease? It gets interrupted and it causes pain. So whether we call it spirit, so we have to keep ourselves in high spirits, which is good because it flows through the body. And we also keep our blood flowing. So what is interoception? It's the communication between the brain and the body. And these are the sensations generated by the body. And it is also a process of how the nervous system senses, interprets, and integrates signals originating from the body. This cannot be measured on a scale of 1 to 10. How a person is feeling, that is most important. And this is a message to the caregivers also. We have to care about how a person is feeling. It is not a measure in a numeric order. And we have to remember this. We are not alone. We have support of NIH. NHLBI gave out 10 grants some years ago on Excellence in Hemoglobinopathies Research Award, which generated just by my team a cannabis trial and discovered many integrative approaches and targeting with pharmacological and integrative approaches of pain, which included nutrition and companionship, which reduce pain. And the National Center for Complementary and Integrative Health has awarded us, along with Dr. Wally Smith and Claudia Campbell, another big grant to really promote and advance the sickle cell disease pain in a new direction, not the way we were doing, being alone. They want us to bring together everybody. And sickle cell disease, believe it, in the last few days we heard it's African Americans. No, it's a global disease. There is a very large burden recently recognized in India, which has put $11 billion, provides free treatment and free facilities to all the persons with sickle cell disease, and have put them under handicapped category, extending them all the privileges of handicapped. How are we accomplishing this agenda of NCCIH? We call this program Sickle Cell Disease Pain Analgesia and Integrative Network, or SCD Pain. The first theme we have is science without borders. Scientists should not be shaking one tube at a time in their own labs. They should collaborate. Different fields should come together to solve this whole issue. We should promote the future. I'm getting old. I need somebody to follow it. And we are training early stage investigators on multidisciplinary aspects by having providing them hands-on training. We did one in July, and people from different specialties came together, and they felt we never knew that we can work together, although we are from different areas. They were so excited and started working together. We are giving out pilot grants to start new directions, but they have to be new directions which really would mean something to resolve the issue of pain in sickle cell disease. And this is not only restricted to trainees, but those who are established investigators. We want them to move a little bit away from all that they know and learn new things. And then the third theme is hub to health. What is the use if we keep doing things in our own labs and not bring it to you and not learn from you? So it is a networking of experts, which we did, and the community leaders we did last month in LA. And we had a lot of warriors, and all the scientists felt, who had never heard the warriors from Painfield, that this was the most inspiring meeting, and we have learned a lot, and this is something we should be working on. And we have a very interactive website. Please join it. I'll show it to you at the end. And then dissemination and publication by being in the meetings, talking to everyone on a one-to-one basis, and making presentations, which I am doing, and publishing this. We also came up with Oscars for pain research. Why not? We live in LA, right? Outstanding scientific creativity and research. And what we did, we put these people from different parts of the country, different fields, into 4 different groups. They never knew each other, they didn't know about each other's work, and asked them to come up with ideas that are needed, that are major gaps in the understanding. There were 4 themes: whole person health, and somebody came up from 2 different ends, Carolina and San Francisco, together to actually study the women's reproductive health, and somebody else wanted to do the gut microbiome, how it affects pain. The second was mechanism-based integrative approaches, and this was very impactful because they want to see how social interaction affects the neuromodulation and pain. Oh, this clock is moving really fast. And the third theme was advancing technology for integrative health. We are not really making the use of technology to address whole health. And these people came up with the idea that they can use a different kind of recently developed MRI, which can be rolled next to the patient's bed or the chair. And they can image it there, and then with AI, they can find all that happens in the body. And they should do it longitudinally because it's cost effective, it's convenient. And these are the things we want to use. And then we had the 4th theme, how circadian rhythms, sleep, and all these interplay in the multi-organ damage and related to pain. So these will be presented at the annual sickle cell disease meeting in NIH on October 27th. Everybody is free to join. There is no registration fee. And I will show you now a small clip of how what I am saying is true. We took sickle cell mice, which have the same disease as the people have because they express the human red blood cells, which are sickle. And we kept them isolated or kept them happy. A male mouse with a female gave them very good food, and then we withdrew everything and caused trauma. And what happened? The mice that were happy had lower pain in the middle. And the mice that were single and were actually traumatized on the left and right had more pain. And this correlated with the molecule serotonin in their brain. When the serotonin went up, the pain goes down. And this is how, as somebody showed yesterday, duloxetine works. It works on sickle cell pain. So instead of giving duloxetine, we can improve the environment and achieve the same results in the brain. And this was not just the behaviors. When we took these brains out and looked at their sections, not only the nervous system cells, but every cell. Cells of the vascular or the blood vessels, the immune cells, all were affected and adversely affected under isolation, causing pain. And this proved that the mind and body are connected. As shown in this figure, the brain gets the signals from the gut because the gut microbiome changes every time we take any medicine. And the brain, when it senses cues from the environment, companionship, good food, affects the whole body. So don't be alone like the guy on the left on the top. Share the burden and eat healthy to get the good signals to the brain. And then with this, I would say, I'm not alone. This is a work of a big team of my trainees and my amazing collaborators, NIH and other funding agencies who have supported this work over the last 20 years. And with that, I think you are my teachers, and I will thank you. And I thank everyone for what they are doing for sickle cell disease. And here is the website, and here is the QR code. You can scan, and you can get on our mailing list. We have more than 260 members already. That includes everyone, all of us. Please join, and if you have any questions, you can always send them to me anytime. But our website is something that you should join and take advantage of many things that are happening the year round, including this month on 30th, we have a webinar organized by our own Dr. Wally Smith on different aspects of pain on 30th of October. And let me tell you, everything that we are doing is free for everyone. Nobody has to pay anything. It's funded by NCCIH. Thank you.
Thank you, Dr. Gupta. A round of applause for Dr. Gupta. Now I need everybody to pull out your phone and scan. I mean, we had that presentation wrong, so I need y'all to scan that code. Yes, we do. Thank you so much, Dr. Gupta. We appreciate you one more time. And now next up, we're going to keep the slide up just for a few more seconds. And as we transition to our next doctor, is Dr. Visa. He's on his way up. And a round of applause.
Good morning, everybody. Good morning. All right. Thank you for having me back. I think a lot of you saw me yesterday. My name is Madhav Vissa. I'm a hematologist at UCSF. If you didn't see me yesterday, then good morning. It's nice to meet you. The organizers, for some reason, decided they wanted to hear from me twice, which is shocking, but thank you for the invitation to talk about pain management. And I think that this is an interesting topic, this question, what is pain management? I had a little bit of trouble kind of sorting out what that meant, and figuring out how to present to you a pretty holistic topic to introduce what's going to be coming after me in terms of novel approaches or different approaches, integrative approaches, things that we keep in our toolbox to manage pain in a way that may or may not be really studied or generally practiced by my colleagues. And so I think that all together we need to be able to bring these tools to our clinical spaces, to our homes, to our hospitals, and share them with everybody in order to make sure that we are doing the right thing for sickle cell pain, which is importantly different than other kinds of pain. So the topic today is what is pain management? I do want to maybe just take a little bit more of a clinical approach to this and share with you some of my thoughts when I'm interacting with a patient, either in the clinic, in the hospital, on the phone, sort of how we think about what methods to use to manage pain. So I'm going to take a little bit more of a conventional approach, and then I think people who are speaking after me are going to share some of the more novel approaches. I don't have any disclosures. One of the things that I think really pops out in my mind when it comes to pain management is that there is a clear difference between pain management and sickle cell management. And I often tell my patients in clinic that you deserve better than just pain management when it comes to taking care of your sickle cell disease. Of course, pain management is essential. Effective pain management is essential for overall sickle cell care, as I described yesterday. An increased severity of pain correlates with increased mortality in sickle cell disease. And we know that if sickling is happening in places that is causing pain, then it's happening in places that are not causing pain as well. And organ damage is one of the leading causes of mortality in adult patients. And so because of this, we focus a lot of our efforts in clinic on screening, prevention, and disease modifications as essential components, not just for the background of sickle cell disease, but for the purpose of pain management. And so in clinic, when I start a visit, especially for new patients, I say, what are your goals today? What are your priorities? And oftentimes it is talking about pain management. It's talking about creating pain plans. It's talking about how to engage with inpatient or ER providers. But then I say, let's talk about your agenda. My agenda is to discuss that, but also to talk about what is going to prevent you from getting sick in the first place. Why don't we, in addition to treating pain, treat what's causing your pain so that we don't have to treat your pain as much, right? And again, pain severity may be a surrogate marker for disease severity. So it's important to me to not distract from pain management in the clinical setting and not say like, no, I don't want to talk about your pain. I want to talk about hydroxyurea. Hydroxyurea is, in my mind, a pain management strategy to reduce the severity of disease. And here are some key aspects of pain management that I think are going to sort of inform how we talk about pain for the rest of this talk. So, of course, prevention is key. Why would I want to treat pain if I could prevent pain? And a lot of that has to do with disease-modifying therapies like hydroxyurea and DARI, transfusions, et cetera. Another key aspect of pain management is how it's cared for in different settings. Of course, what you use at home is going to be very different than what you use on day 15 of a hospital stay, right? And vice versa. There's a huge difference between acute pain management and chronic pain management. Those are absolutely separate things and cannot be thought of in the same way. We have to engage with pharmacologic, so medication-based therapies, and non-pharmacologic therapies. These are things like acutherapy, massage, meditation, lifestyle changes, etc. And then I think that changes over the lifespan is really important to me. I am both a pediatric and adult hematologist, and I take care of people across the lifespan. And what I've really noticed is that this adolescent and young adult age group is when not only are personalities and emotions and feelings of autonomy changing, but really the way that pain is actually felt changes. And it might not be abrupt, it probably isn't abrupt, and I'd be so curious to hear from warriors in the room sort of how they experienced a change in their pain phenotype over the course of their young adult life. But it might be really confusing to hear that what worked when you were a kid may not work as well when you're a young adult because the pain is different, even though it may or may not feel a lot different. So these are just a couple of the aspects of pain that I think about when I'm talking to a patient in the clinical setting to help inform how we are going to make a plan going forward. And I think we've seen this graph several times by now, just showing the natural history of a pain episode. This is adapted from Dr. Ballas and his colleagues. Excuse me. Really showing the key here is that the onset of pain can be gradual and it can be abrupt. And there can be, some people tell me, I feel like there's a crisis coming and I feel like I need to do something now to prevent this, or, the ship has sailed, I'm probably headed to the ER within the next 24 hours. What I think is really, really important about this graph is this established phase, the fact that it is essentially a constant phenotype of pain. The way that pain is often managed in the acute care settings, in the ERs and in the inpatient setting, is with short boluses of short-acting pain medications, a dose of Dilaudid and nothing else in the background. And why would I treat something with an episode of pain management when the pain is constant? We need something constantly in the background, and we need to address the nature of the pain in order to effectively treat it. And then the resolving phase, I think, is also important to keep in mind, that somebody may or may not be back to their total baseline by the time they're ready to leave the hospital, that we might need to come up with a plan to wean, to kind of get someone through the pain episode. They may or may not need to be in the hospital, but they do certainly need acknowledgement that the pain hasn't gone away, that it might actually still need to be managed even without IV pain medications. And then all of you are aware that there are provoking factors, sometimes called triggers. These are just a couple of them, and I'm sure that there are many others that are known to people who live with sickle cell disease, but the ones that I tend to hear about are abrupt temperature changes. Where I work in San Francisco, the temperature changes like moment to moment in these microclimates, and sometimes that can be really difficult for our patients who sort of rely on their blood vessels being adapting and acclimating to the current climate. Even things like getting out of a pool really quickly or getting out of the shower really quickly may be a trigger for an acute pain episode because of the way that it impacts the blood vessels. altitude. A lot of people don't live up in the mountains, and when I have people traveling, I have a patient who traveled to Bhutan recently, which makes me very anxious since it's like in the actual Himalayas. So I begged her to hydrate and do whatever she could to prevent her from having a crisis. We transfused her before she traveled. Dehydration, I mean, how many times in your life have you told drink more water? My water's over there. I regret I didn't bring it over here with me. Illness, so just even viral illnesses, we talk about the increased risk for, thank you so much, how kind. We talk a lot about how people with sickle cell are at increased risk for infection, and it's a little misleading because I beg you to get the flu shot in clinic. People with sickle cell aren't more likely to get the flu than people without sickle cell. It's really other infections that are more of a concern, but if you get the flu with sickle cell, you're more likely to get sick from it than someone without sickle cell. It might provoke a crisis, it might provoke acute chest syndrome. And so those are the things that I really try to do for the best of care of my patient to make sure that we're reducing any potential for triggers. Stress, my goodness, this could not be emphasized enough, that stress and emotional hardship can make a big difference. Physical exertion, we all are told to exercise, we're all told to go to work and try to have functional lives, but sometimes that's really in the way. Intimacy, that can be really painful for some people, not to mention the impact of depression, anxiety, mental health, and the environment. I write a lot of letters for patients saying, hey, they can't live in this place that has mold in it. They can't live in this place that has a broken air conditioner because dehydration from sweating all day is going to be a triggering event. And I learned this from one of my patients probably a lot later than I wish I did, that much like pain, avoidance of pain may have an impact on quality of life. I got a guy who says, yeah, I don't really have pain that much. I take my daily chronic pain meds, but I don't leave my house. I don't do anything. I have a boring, empty life. And it's because if I did anything that would make my life more interesting, I'd be in the hospital with a pain episode. And I think that was a really, really important shift for me in my thought process about how people perceive pain. You don't have to be in pain to have an impact on your quality of life. And that's something I really take forward with me as I talk to patients. Oh gosh, that time is moving quickly. I hate that I have to say this out loud. Patients want and deserve optimal pain control, and they want the best quality of life. Why on earth would I need to say that? This is something that I think my colleagues do need to hear more often. In the acute care setting, it's important for us to listen to patients, listen to their self-reports. I always say, you are the expert in your pain, and I get to be the expert in what's safe, and let's meet somewhere in the middle. Although pain may be the presenting diagnosis or presenting symptom to the ER, it can be associated with other complications. You're more likely to have a stroke or acute chest syndrome when you have pain. And so we have to make sure that we're not anchoring on pain being the only symptom, that we're looking for anything else that could be causing danger to someone who presents for acute pain. And then we base our decisions on our multimodal assessment. We base it on what your outpatient use is, what your knowledge of what works for them are. We minimize the side effects of medications and make an individualized pain plan, or what I like to call care plans, actually, because we know that works. And so the rest of this talk is really going to talk about ideas and suggestions that I have, but the only thing that matters is what works for somebody. And so take the rest of this with a grain of salt, because these are just sort of my toolbox of medications and interventions that may or may not help individuals. Individualization is the key. And even though the patient report is the gold standard, that doesn't mean that providers don't have tools in our toolbox. We don't have some ways to help make an assessment. And I obviously, when I'm in pain, I don't really want to talk about it. I don't really want to tell somebody sort of what they need to know in order to help me. I'd like somebody to help me without me having to show up the whole way. And I can imagine that that's true for many of our patients too. So here are some tools that our providers can use, looking at some objective features like the location of pain, the quality of pain, the intensity of pain, and these might help shape what our interventions are. As somebody mentioned yesterday, a burning or like tingling pain might be treated very differently from a sharp stabbing pain, and might be treated very differently from a cramping pain. And of course, we want to make sure that we're not missing some alternative etiology of pain like appendicitis or an ectopic pregnancy. I like to use terms like, does this feel like your sickle cell pain? So that I'm not necessarily minimizing and saying like, it's typical or whatever, it's the same old, but to make sure that I'm not missing something new. And I often ask, is there anything new about this pain episode that you think you're worried about? Objective pain scales are important. Of course, my 9 and your 9 might be different, but your 9 and your 8 probably is a meaningful difference. And so the quality and severity do help us make our interventions. We have this tool sometimes we use at our children's hospital that people can actually like circle things and write them down just so that it's a little bit easier to visualize. And I'll use a case presentation just to kind of help guide some of the rest of this talk. So I have a 24-year-old guy with hemoglobin SS who's coming to see me in clinic for routine care. He's had a few admissions in the past year, and it does seem to have increased in frequency since he transitioned from the pediatric program to adult care at age 22. At the time of transition, he wasn't taking any regular medications other than hydroxyurea, but recently he has been taking oxycodone as needed about 3 to 4 times a week. In the last month or two, he's been asking for refills pretty much every month, which is new and different from what he came to me on. So here's a couple of principles of home pain management, things that we want to do to talk about reducing pain in the clinic. The first thing to do is, of course, optimize our non-pharmacologic and non-opioid strategies as much as we can. Things like preventing triggers, things like hydration, warm baths, heat, etc., staying fit, staying healthy, focusing on nutrition. And then, of course, I don't want to prevent you from getting good pain relief, but I do think things like Tylenol and ibuprofen are absolutely the first thing to try, which are non-sedating, they're relatively safe, they are over the counter, and so they're easy to access, don't need a prescription, and important to optimize before we move on to the next step. If we do need to, of course, I do make sure our patients do have at least a small supply of short-acting opioids, things like oxycodone, Norco, et cetera, to treat sort of little blips in pain that can be managed effectively at home. If I notice that someone is taking a lot of short-acting pain medications requiring monthly refills, I do consider adding a long-acting opioid, something like MS-Contin, OxyContin, methadone, or buprenorphine. And because I'm assessing that this is transitioning more from episodes of pain to a chronic daily pain. If you're needing a lot of short-acting medications, then I don't want that to interrupt your life. I want you to have pain relief throughout the day and not need to rely on short-acting medications to get through the day. And then we also want to explore any underlying new causes for pain, things like avascular necrosis or bone infarcts. And so we want to make sure we're getting imaging, making sure we're referring to the right specialists for that. Importantly, if there is an impact of mental health, I want a psychologist, I want a primary care doctor to be involved, and pain specialists, because again, multimodal assessments and multimodal therapy are necessary. Often I'm referring my patients to physical therapy, which I'm very, very pleased when people tell me that it's effective, because I hope that we can have some people give testimonies to the impact of physical therapy. It really is quite key. And in the background, of course, we want to optimize disease-modifying therapies like hydroxyurea, Endari, crizanlizumab, et cetera. Hopefully many more to come, as you can tell by the tables out there. Again, here's just a little list of some of the outpatient pain management tools that we have: NSAIDs, Tylenol, oral opioids. Sometimes we use other non-opioid medications like Flexeril, gabapentin, et cetera, or topical agents like lidocaine or Voltaren. These are all things that I just explore based on the nature of pain. Chronic pain management does require a slightly different approach, things like duloxetine, which I think you've heard about, methadone, buprenorphine, something that's long-acting and treating the constant nature of this pain in addition to the episodes. And then optimize disease-modifying therapies. Non-pharmacologic therapies, I think all of you have a lot more to teach me than I have to teach you about this, things like hydration, warm baths, avoiding triggers, and integrative therapies, along with psychotherapy. At Children's, we actually have one of these. I don't know if any of you have seen it. This is a pain action plan for home. We stole this from asthma when it comes to how the symptoms are. So you can sort of read this like a stoplight. It's a green, yellow, and red zone. Green means go. You're not limited by your pain. Either you have no pain or the pain is minor enough that you can actually get through the day. This is where the medications might include things like your daily chronic pain meds. This might include short-acting Tylenol or ibuprofen, something pretty mild if you have just like a little bit of a discomfort, but it's not stopping you through the day. And I know it's a little small to see, but there's some descriptions of what that might feel like for the patient. Yellow means like I'm not totally stopped, but I'm slowing down. I'm a little uncomfortable. And this is where we might add on an oxycodone or a Norco or something short acting just to kind of like reduce the intensity so you can get back to the green zone. And the red zone is where you're really kind of stopped by the pain. This is when we're trying to do as much as we can to avoid going to the hospital, but really starting to think about going to the hospital if possible. On the back of this sheet, this is a front and back sheet, is a lot of sort of general strategies that I've already talked about, avoiding triggers, hydrating, et cetera. And we're really lucky in our clinic at Children's Hospital Oakland to have a psychology team, a social work team, really a multimodal team to go through this pain plan with patients and really teach them from all disciplines how to take care of themselves at home. Because our goal is really to keep you in the green zone as much as possible, right? So a little bit more about this case continued. On further history, it sounds like the pain used to mostly be in the low back, thighs, and hips. And so that raised our suspicion for something like avascular necrosis. And when we did an exam, we revealed that he had limitation of internal rotation. That's the leg turning in of the bilateral hips, but the right was a little bit worse than the left. And he was open to investigation. He said, yeah, I'd like to know what more is going on. So we ordered x-rays and sent him to physical therapy. And the x-rays showed that he indeed does have avascular necrosis, or at least suspicion for avascular necrosis, with narrowing of the joint space on the right. He started physical therapy, and we also referred him to orthopedic surgery, not necessarily saying, hey, go get surgery, but hey, can you talk to a surgeon so that they can discuss what the options are? And he was open to starting a long-acting pain med because he was noticing, especially like, yeah, I actually have to wake up at 3 a.m. to take an oxycodone, and I'd prefer to get a good night's sleep. And we uncovered that not sleeping through the night was probably a big contributor to the severity of pain during the day as well. And so we started a long-acting pain med as well as some other non-opioid medications like duloxetine. And after more discussion, he was agreeable to connecting with a local therapist, starting duloxetine, and was open to trying Endari as well. So this is kind of a very ideal situation. Of course, there's a lot of communication skills that are required in order to get to this place. And just a brief note on transitioning to long-acting pain meds. I want to make sure that people are getting at least as much opioid as they were getting when they were only on short-acting. And so I calculate something called an oral morphine equivalent or a morphine milligram equivalent. There's a chart on the right that just basically converts like all oral opioids to a morphine dose. And you can use this number to very easily kind of separate out what your long and short-acting meds are. Most of the daily morphine equivalents should be given as a long-acting, with the short-actings on top of that. And this is because what we're really trying to cover is the constant nature of this pain, not the escalations. Breakthrough short-acting, though, are important to make sure that people still have. A couple of challenges that I've encountered with outpatient pain management and that have been described in the literature. A lot of my patients do feel very comfortable with their current pain regimen, even if I've assessed that it's maybe not as ideal. There's sometimes a little bit of a reluctance to accept that things should change and that short-acting pain medications aren't the only way to address this. And the way that I like to frame it is always, I want to give you good care, and I'm observing that your care right now might not be as optimal as it could be, especially when it comes to the impact on interruption of sleep. So reluctance to change the current regimen is often a barrier. This is way more of an issue in the public sort of perception than it is in reality, but comorbid substance use can be an issue. I have very, very few patients who have either cocaine or heroin in their body that makes me very concerned about prescribing short-acting pain meds, and I say, I'm in the interest of taking good care of you and not killing you, and I prefer not to give you medicines that could facilitate your death if there's other substances in your body that I worry about. So I'm pretty open and honest and transparent about substance use and want to make sure that my patients feel safe talking to me about it, but I also want to be open and honest and transparent with my fears for health and safety of patients who are using other substances. Cannabis is no big deal, whatever, just don't get on the road when I'm on the road. Frequent hospitalizations may interrupt the regular prescribing cadence. And so if I'm prescribing a monthly supply of meds, but 2 of those weeks are in the hospital, then it's not really right for me to prescribe at that month mark, right? I got to account for that time in the hospital when someone presumably is not taking their home supply of medication. And so there's a lot of reconciliation with our pharmacies, with our inpatient hospitalizations, and it can be a little bit of a challenge for chronic pain management. Some people just don't tolerate certain meds. Some people get really itchy or sleepy or just nauseous with Dilaudid or morphine or whatever. And so we have to make sure that we're looking back at someone's history to pick agents that are effective. And I do ask our patients sometimes to try things that they may have not tolerated in the past if we have other alternative ways to support their symptoms. It's tough for me to justify using strong opioids when we haven't optimized our non-opioid regimen. I'm not saying that we shouldn't use opioids, but we should use them in addition to multimodal therapy, not instead of it. And so optimization of the non-pharmacologic and non-opioid agents, especially things like psychotherapy. If someone is depressed, Dilaudid isn't going to help depression, right? Dilaudid helps pain, but if what's causing your pain is depression and anxiety and an emotional burden, then we have to treat that as well. Again, not instead as well. Sometimes it's really tough for our patients to go get their x-rays done, go see the orthopedic, go make an appointment with physical therapy, whether it's because of fatigue, scheduling, transportation, et cetera. I recognize those challenges and I do want to work within those limits. And rarely, but importantly, there is sometimes a limited insight. Some patients just don't recognize the impact of their mental health and their mood on how it's impacting their pain. If someone says, "You're wrong, duloxetine is not what I need, Dilaudid is what I need," then we reach a little bit of an impasse, and I try to approach that with compassion. So a couple of takeaways for outpatient pain management. Again, this has to be individualized based on the patient's pain. Is it daily versus chronic? Is it intermittent? This is really important to make sure that it's not a one-size-fits-all approach and that we're taking each individual's experience into hand. So it takes a while to come up with this regimen. Almost no one who's on daily opioids should be only on short-actings. They should be available, but a long-acting or something chronic in the background to treat chronic pain is necessary. And we strongly encourage the use of non-pharmacologic and non-opioid agents in addition to opioids. And then importantly, treating pain is not the same as evaluating pain. So I want to make sure that we're treating avascular necrosis, bone infarcts, et cetera, depression, anxiety in the background. And so moving on, I know I don't have that much time left, but to talk about acute pain management a little bit, many sickle cell complications occur in the setting of a pain crisis. And a couple of things that I share with our inpatient and hospitalist groups is it's almost always okay to continue what the patient's on at home. We try to avoid transfusions unless they're necessary. And of course, if a patient says transfusion helps them and it makes them feel better, then we incorporate that thought process. But I don't want providers to just say like, hey, the blood transfusion is going to be the treatment for this pain. It has never been shown to be a clear benefit in sickle cell pain, although if it does help, I include it in the individualized plan. I think early communication with the outpatient team and the hematology consult service can be really helpful, and I put my number all over the patient's chart to make sure that providers are able to contact us and we can collaborate on early intervention to be aggressive as possible. And then just a reminder, this is more a reminder to the providers, that sickle cell is an inherited condition and our patients are the experts on their health, and that their report is the gold standard. There is no lab value, vital sign, exam finding that proves a patient's in pain or proves their severity. You know, I got a call yesterday saying, hey, their white count is up, so they must be in more pain. I was like, well, maybe, but it's not because their white count's up. It's because they're telling you they're in more pain. That's what I believe. We have a couple of pathways in our emergency room at the Children's Hospital Oakland for rapid triage, which is an evidence-based. Unfortunately, not a lot of ERs have this. But what I do like to have is something like this. This is a template emergency room pain plan, which actually I can share with you our website that has some of these kind of templates on them. Which not only gives a framework for how to take care of sickle cell pain, but importantly, it looks the same for everybody. So when an ER doctor opens up the chart and they see this, over time, my hope is that they can actually just recognize this as a pain plan and say like, oh, this person has a plan, let's go for it, let's work with it. We try to encourage the use of things like intranasal fentanyl or something before an IV is established, because I understand that IV placement can be can be a long wait and can be difficult and might exacerbate some pain. And so we do recommend things like intranasal fentanyl or some sort of pain relief before an IV is placed. As soon as possible, we recommend a thorough exam and history, but really not to delay any pain management. And then you can see the rest of the components of a pain plan here. I won't go through this, but this is just something that we have prepared for our emergency room to help facilitate just how to take care of sickle cell pain. Sometimes we hear the words, the patient failed ER management. I flip that in my mind. I say that ER management failed this patient and say that if it's really the nature of this pain crisis that can't be dealt with in the emergency room alone, that the inpatient stay is probably necessary to get through the remainder of this pain episode. And so we do recommend usually if after 3 doses of IV opioids hasn't sufficiently reduced pain such that someone feels that they can comfortably take care of their pain at home, that we recommend admission. And of course, making sure that our teams are aware to look for any other sources of pain or organ damage in the hospital. A couple of principles that I share with the inpatient teams when it comes to inpatient pain control is, again, to focus on this constant nature of pain, that something has to be in the background always. We cannot only rely on short acting. And so some sort of basal pain relief. Very few places still use a basal infusion, like a continuous drip of morphine or Dilaudid. We do have a lot of concerns about that, and in our upcoming guidelines from the National Alliance for Sickle Cell Centers, for adults, we're recommending against basal infusions. That's not to say that we're recommending against basal pain control. And the way that that looks is usually either a scheduled oral or IV opioid, or at some institutions where it's feasible, an infusion of something like ketamine or lidocaine. And then we want to optimize our pharmacologic, both opioid and non-opioid, as well as our non-pharmacologic methods, as I've already discussed. If intermittent dosing, so the nurse coming in every 2 to 3 hours, is not sufficient, consider using a PCA, which is the button that you push to administer a dose to yourself. We are moving towards that becoming more of the standard of care. And of course, pain management has to be individualized, titrated regularly. We do want to make sure that there's expectation setting, that the patient is aware of what the changes are, that they feel comfortable with those, and that weaning is part of the plan, not necessarily a punishment. I don't want to ever frame that we're trying to take something away from you or that we're interested in people suffering more in the hospital. It's actually important for us to frame this, that reduction of pain medicine actually is the treatment for your pain, because long chronic exposure to high doses of opioids may increase the sensitivity of the nerves, may reduce the effect of the nerves, and may cause other problems like constipation, itching, et cetera, that are probably causing more problems than not. But again, none of this is something I can prescribe without talking to the patient and understanding what is necessary. A word on ketamine. I don't know if anybody has used ketamine in the past. We have used it a lot more frequently, especially at our children's hospital. It has a very different mechanism of activity compared to opioids, but a couple of things that it does is it has its own pain relief property, but another thing is that I don't know if anyone has this experience where the first dose of an IV opioid is the most effective, and then every dose after that is a little bit less effective. What ketamine does is it tries to increase the effectiveness of every subsequent dose so that the relief is a little bit more sufficient. Unfortunately, at some institutions, this is only done in the ICU, but hopefully, as we learn more about this and get more data, it can be a more standard of care use in the hospital. This is an example of what an inpatient pain management plan looks like at our institution, and it breaks it down to make sure that there's a controlled wean, that there is a scheduled oral opioid, that there's an NSAID, there's Tylenol, and ketamine. And again, as was mentioned before, these are not instead. We're not trying to make you fail Tylenol before giving you an opioid. All of these are given together. And then a breakthrough IV opioid, which is sort of the key wean. I have day here, day 1, 2, 3, 4, 5. That sort of used to be our framework. I think I'm moving more towards a step and recommending that each step takes about 24 to 48 hours. Again, we want to make sure that there's a clear expectation both from the team and from the patient of how we're moving forward in pain management so that it reduces conflict and gets everyone on the same page, that our goal is to actually take good care of people, not to punish someone for being in pain or to nobody enjoys when somebody is suffering. And so I do think that that's a key to share with both patients and providers who are managing an acute pain episode. Importantly, this includes a lot of additional therapies. So constipation, itching, nausea, vomiting, insomnia, anxiety, muscle spasm, urinary retention, and dehydration. These are all components of pain management that need to be addressed, often either because of the pain itself or because of the side effect of opioids. Okay, and my time is up, so I will move on. In-center spirometry, I always tell my patients, this is the most important thing that you can do to prevent yourself from getting worse in the hospital, so please, please, please use it. Unfortunately, at the adult hospital, there's no like owls and squirrels on your in-center spirometer, but steal one from children's and that'll be that. I think I've already mentioned this, that we want to make sure you're getting at least as much pain medicine in the hospital as you were getting outside of the hospital. So please advocate, hey, I take MS Contin at home. Can you at least make sure that I'm getting my regular chronic pain meds at home instead of relying only on the short acting? And this is where communication with the outpatient team is key. So I definitely advocate for you to ask your teams to call your outpatient providers. And if you don't have an outpatient provider, call anyone who might be able to help with sickle cell disease. So this is the last slide, I believe, that the gold standard for evaluation of pain is what somebody is telling me. I can't assess anything beyond what the patient is reporting. We have to use a multimodal approach, including both opioid and non-opioid, and pharmacologic and non-pharmacologic. And pain has to be individualized. We have to make sure that we're checking our language and biases in the experience of patients, because it can be really distressing, I'm sure, both for me and for patients to hear biased and racist language when it comes to pain management. And with that, I thank you, and I'm happy to take questions whenever appropriate. Are we doing questions
Thank you
now?
so much. We are going to have some questions on the virtual side as well. Dr. Gupta, they have a question for you as well. So I want to make sure that we are able to get your answer to that question. If anyone has questions, please line up. But we are going to take about 4 questions and then move on to the next session. But virtual people have been asking questions all morning, so we want to get their questions. Can we go ahead and go to our virtual?
Absolutely. The first question here I have is, should colon cleanses be provided monthly in order to help absorption of nutrition?
That is a really interesting question. Colon clinics, huh? Do you want to take this or do you want to?
Colon cleanses.
Well, I think one thing I'm not very much aware of those clinics, but one thing that I have been asking all along is that we should pay attention to nutrition. We have a lot of attention to every other aspect. We have them see the psychologist, but a dietitian who understands sickle cell disease requirements is a necessity. And how the food should be prepared, not just high protein or high fat, but what kind of protein and what kind of fiber is needed is very necessary for everybody, but more for sickle cell where the energy requirement is very high and good energy is necessary. So it's not that it is all that is needed, but it's an important part of good health.
So if you guys look at the food that your folks in the hospital take home with them when they're discharged, the things they've collected, the sodas, the cookies, they have so much. It's like packing a suitcase to send them home. And so I think that we really need to do a lot more dietary stuff for them within the hospital. Then we wouldn't have to worry about colon cleansing because we'd be teaching them how to eat properly, living with a condition that may lead to having some problems related to that.
The only thing I'll say, the only thing I'll mention about some sort of more, not totally evidence-based interventions like colon cleanses is colon cleanses sound like a good way to get dehydrated. And I really hesitate, even things like Ozempic or other ways. I really want to focus on lifestyle modifications and healthy weight. And of course, in addition to having sickle cell, all of us are just regular adults living in this world. And I tell my patients frequently, you deserve better than me for your primary care. And so as long as we're making sure we're not dehydrating, we're not doing harmful things to our bodies with any lifestyle interventions, then I am completely supportive of it.
So Adrian and I laugh all the time about the things that her daughter packs up and takes home, and all the other children that come to the hospital pack up and take home. So.
And I think really it has to start in the peds, right? The food, the choices. I know my kids grew up with me being very strict about diet and everything, but when they would go to the hospital, the nurses and everybody wanted to make her feel better. And then she would get these packaged cookies and she would get all these things, so I understand it. Also, we need to talk about what sickling actually does to the GI tract. And the combination, the effect or connection between bone marrow health and gut health and brain health. I think understanding how that all works together gives you more reason, right? Because you have to have a reason to not do that thing that's going to give you an instant gratification. Because I really like chocolate. I'm going to be honest, I like some chocolate, but understanding it. So I think we have to do whole body health and education. So I'm really thrilled with this.
That's a very good point you make. Little treats is not bad for children as long as overall nutritional requirement is met. Now, for example, the gut microbiome is very important, and there is a direct relationship shown in human studies also that it does have an impact on pain and other conditions. But the gut microbiome is modified by even hydroxyurea and all the drugs that we are taking. So there is even more reason to have a more nutritionally balanced diet. For example, people take yogurt. Probiotics have become mainstream food now. But all these yogurts sold outside have 100 things in them that you can't even read. I stop reading when there is a big density of anything because yogurt should only have milk and cultures. So which product should I use is also very important. I have seen children getting hooked on sweet yogurt. It's nothing but sugar. And so we have to learn a lot about in this world where we are full of aisles and aisles of multiple things, eeny, meeny, miny, mo, which one should I pick? It's like that. So awareness and learning, and also having primary foods that you can just make yourself, or you can buy in a whole condition and then just prep it yourself is the best.
Maybe we'll move to the next question.
We're going to go to one in the room and then go back to virtual. So stay right there, Dima.
Testing. Okay. Dr. Visa, I believe you brought up the importance of treating acute as well as chronic pain simultaneously. And so I've been in the ED and then also transitioned into being hospitalized. And what would you recommend for medical providers who may be apprehensive to prescribe different pain meds to help with both?
I think the first thing I would recommend is to reach out to first of all, if there is a pain plan, which I hope there is, to look at it and use it, because I think that sometimes people see doses that they're not comfortable with, that they haven't used for other people. But to go back in the history, to talk to the patient's outpatient providers, and if they're not willing to listen to the patient themselves, which would be ideal. I think that I've had a little bit more success in conveying sort of what my history is with patients, what my experience was with talking to them, and getting providers to be a little bit more on board with management that they may or may not be uncomfortable with. And as I think somebody brought up yesterday, really exploring, what are you worried about? Are you worried that this person is drug seeking? Are you worried about their safety? Are you worried that they're faking it? Like what's making you concerned about giving this person a drug and dose that you don't want to? And really trying to sort of gently and politely, and sometimes less politely, kind of call their bias and expose that your reluctance may or may not be real. It might be because you are behaving out of your implicit biases.
Right. So it sounds like you're saying the importance of consult if you don't want to listen to the patient.
Yeah, and I love the idea. Somebody talked about a medical alert bracelet having the pain plan like in there. But one of the key parts of this is our phone number and a way to contact us so that we can advocate for you too.
All right, let's go ahead and go to our virtual question.
So this virtual participant wants to know the details. Is the sickle cell pain action plan available on the UCSF website?
Yes, so it's just a template, and this is an example so that providers and patients can use it to create their own individual plan. We have a kind of generic one for people who've never had pain before or never been to the ER, because we want them to be prepared as well, and it has weight-based dosing, but it is not at all individualized. It's a very sort of general plan. So it's a good place to start. It is not tailored for anybody. It is tailored for a generic patient, and none of you are generic patients. Sorry, people.
Thank you. And now we're going to go in
It's sicklecell.ucsf.edu. I can, if you.
Say that one more time, Doc.
Sicklecell.ucsf.edu. That's just one example. We're not the best. We're just one.
Thank you.
Hi, my name is Kayla. I'm a Sickle Cell Warrior SS, and I have two quick questions. To my knowledge, sickle cell damages your organs over time, over your lifespan. But I also see that being the case with pain management opioids. So how do you navigate, or can you tell which one's worse, like which is doing more damage? Can you tell where the damage is coming from when you're on long-term use of opioids?
I can start, but I think Dr. Gupta might have a lot more experience with this than I do. They're sort of hand in hand, right? And I think that the impact of suffering and the impact of living with pain has an incredible. I don't think that's less important than organ damage. I actually think that it's probably more important. Because again, part of the pain control is pain medicines, but part of it is disease modification. I want to reduce the occurrence of pain by using hydroxyurea transfusions, et cetera. And so if both of those are accepted as parts of, and this is why it really breaks my heart, patients who are only getting care in the hospital and not getting sickle cell care, they're getting pain management, they're not getting sickle cell management. And those have to both happen.
So, yeah, so mechanistically, opioids, particularly morphine, has been known for ages more than 50 years that it activates the mast cells, and that's what results in pruritus or itch. And some patients have it really bad. And that's where changing it may be an answer, but we don't know if other mu-opioid agonists, all those hydromorphone, oxycodone, and fentanyl would do the same thing. But there are ways that it can be antagonized, like there are several trials in our studies we found imatinib can inhibit that effect, but the trials are needed very badly to see that how we can antagonize the ill effects of opioids, because sometimes, as Dr. Visa said, it's unavoidable. The pain has to be treated. It can be lethal, and suffering. So there has to be some way of getting research to do that, and we tried doing that, but our grants didn't get funded. Sorry about that.
I just want to add one thing that we're still learning about the impact of pain medications and other interventions. I don't want to create too much controversy, but something like Benadryl for the treatment of itching that Dr. Gupta was mentioning, we didn't know in the past how dangerous it was, and we now know that there is significant danger associated with especially IV Benadryl. And so I think that there is some trust that we have to ask from our patients as well, and of course we have to earn that trust to know when we are recommending that we stop some pain management or some other supportive management techniques, it's not because we're punishing, it's not because we're taking things away from you, it's because we want to take good care of you. And so as you're alluding to, sometimes the risks of the treatments that we're using may actually not be worth it when it comes to protecting organ damage. And that's our entire goal, is to keep the person well, not just pain under control.
Thank you. And then I just had one second part really quick.
Okay, so we are really past time. So what I would like to do is make sure we get somebody else's question. Thank you so much, Kayla. And Dr. Visa, you're gonna be here for a while? Yes, so he will be willing to talk to you afterwards. So if we can go ahead and get these last questions and we can go to the next session. So sorry about that, guys. We gotta go on.
Karen, one quick, mine will be really quick because I want you to think about it. I'm sorry. And that is, we're going through asking the warrior and the family members what works. Could you do some thinking? You don't have to talk about it now, but what are we going to put in place with what works for us, right? That particular drug is not available. And how do you, in your planning, have a plan B for something that may not be as effective? So you don't have to answer it. I want you to think about it and I'll find you.
We collaborate and we brainstorm and we try to be creative, that's all.
Thank you for your presentations and for being here. I just wanted to say thank you also to Dr. Raleigh, because our son, he's now 31, but when he was a kid, he would just have, pain meds now and then. And then as he got older, he's had way more chronic pain. And it was just like adding more and more and more year after year. And we didn't know that there could be options until we talked to other patients and warriors here, actually, a couple years ago. So we kind of worked on it. It took a while, but he's on a different plan right now. And it's way better, and he's been able to decrease the opioids a little bit, which is awesome. But it shouldn't be I'm just saying, you guys might need to anticipate it more, that it might happen sooner, instead of, it's like we're all like, what the heck? You need more, It's like we didn't know. So that's one thing. And then the other thing is, I really think, especially at UCSF, you guys have the power. You got to get more regional center support for these people. I get 20 hours a week of IHSS. He needs way more than that. And I did fight for him and we got it, but we didn't know he had all these issues until he was in his 20s. So you need to get it for the kids before they're 18. Make it a priority, because it helped him get a housing voucher. we haven't even been able to deal with it yet because we really just got it, but it helps with other ways so they can have a life. And I'm just really imploring.
And I could not agree with you more. I tell my patients all the time, you deserve way better than just me for your sickle cell care.
If you guys have the power, you have boards, you have people, you have a mouthpiece.
I'm sorry. Doctor, you mentioned treatment for infarcts and avascular necrosis. Can you expound on that a little bit, please?
Do you want to take that or you want to? Okay, well, I think that there is no specific that just applies to anybody, right? Things like physical therapy, bone injections, hip replacements for avascular necrosis. For bone infarcts, it might be a little bit more challenging, but certainly when we can't treat a bone infarct the same way we treat an acute pain episode. And so adjusting our approach to pain management, and there might be interventions out there, things that an orthopedic surgeon or a physical medicine doctor or a functional medicine doctor might be able to help with, either to reverse the pain or to really treat it effectively. So for some things there are cures and treatments like a hip replacement, and for some things there aren't, but that doesn't mean that there aren't ways to help.
One thing I would like to say, which I should have presented, is that the pain treatment is overrated. The reason is that the disease keeps progressing with age, as many of you have said here. We have to recede or impede the progression of the disease, and it keeps causing more and more pain. So sometimes we say opioid-induced hyperalgesia, we say tolerance, we say that they are non-responsive to opioids. The problem is that the pain keeps increasing because of the increase in the disease pathology. So what we have to do is early on try to somehow, we don't know how, that's the problem with all these new drugs coming in, that if we can slow down the progression of the basic disease so that pain is not evoked or produced or not increased, then that might help. And that is where we want to see overall how we can really prevent or reduce the disease progression, and that would have an impact on pain.